which is the consciousness. Now, when you look at the D consciousness, there is something that says that score for new onset of confusion. No score if chronic. E, which is the disability, we are looking at the patient's level of consciousness, whether the patient is alert, well oriented, whether the patient is confused, whether the patient only responds to voice, like if the patient doesn't respond spontaneously. If anybody enters the room, the patient doesn't even shake, nothing. Patient is semi-conscious and can respond to voice but cannot do any other thing again. So if you mention the patient's name, you see a bit of a twig or something. And then whether the patient reacts to only pain. So patient is unconscious, but when you pinch the patient reacts to pain. Or the patient is unresponsive at all, does not respond to any voice, pain, nothing. So this actually helps us with the patient's level of consciousness. So if your patient is alert, when you're doing the A to E, you put a dot. Now people confuse this and they put an A for alert. You are not, there is nothing that shows that the key doesn't say A is equal to alert. Stick to what the key says. So you see when you got to the air or oxygen, for the oxygen part, the A was equal to air. They wrote it down for you to see. So you can't write an A for oxygen and come and still write an A for alert. Always remember, the alert should be a dot. There is no need for you to put an A. Putting a dot in front of the alert in the right box only shows that yes, you're trying to say patient is alert. Please, when it comes to oxygen, put an A if it is room air, but when it comes to alert, just put a dot. Okay. So confusion, a lot of people might get confused because maybe, let's say, if you get a question that says that your patient has maybe dementia and has a past medical history of confusion, a lot of people seeing that alone will go ahead and point confusion. No, that is not right, because when you read what we read there, it says that new onset confusion. What do we mean by new onset confusion? So new onset confusion is in a situation where your patient has always not been confused, your patient has always been alert, but let's say over 24 hours or over the last few hours, patient has started acting confused, showing signs of confusion. That is a new onset confusion. Something the patient doesn't have, something the patient does not experience on a long term, has not been there over months, has not been there over days or anything like that. That is a new onset confusion. So that is when you can put a pin at the C. But if that is not the first time the patient is being confused, you going to the patient is not the first time the patient is being confused. So the patient has been confused before coming into the clinic, or the patient has actually been confused before and it has already been noted down the patient is confused. Please do not write confused, just write alert, because the patient is alert and the confusion is actually chronic. So if the patient has dementia, has a past medical history of confusion, has been confused more than 3 days and that has been noted down, that doesn't mean your patient is confused. Your patient is still alert, but the confusion is chronic. It's because of an underlying something and it is being tackled. However, if your first time meeting the patient is when the patient is showing you that they are confused, or according to the question, it shows that the patient has been well till 2 days ago, patient has been confused, or till 3 days ago before they brought the patient to clinic, the patient has been confused, and that's the first time patient is being assessed, it is a new confusion. So if the patient has been at home for like a week and the patient has been confused but has never been assessed and doesn't have any record down where someone has put as new confusion and that is being tackled, and that is the first time in a week after the patient has been confused that he or she is being assessed, then that is a new onset confusion. I don't know if that is very nice. So the voice and pain refers to the responsiveness. So if a patient is unresponsive or is comatose or is semi-conscious, they want to know what the patient's level of response is. So if your patient is semi-conscious, does the patient respond to voice? It means when you enter, the patient doesn't move or anything because the patient is semi-conscious. However, when you talk, the patient is able to either shake the head or do a bit of noises or something in response to the verbal command or what you're saying. So the patient can hear you. However, is not fully conscious to be able to be alert, open the eyes or talk or anything like that. And then for the pain refers to a patient that even when you enter into the room, does not acknowledge you because patient is unconscious or extremely semi-conscious and cannot even talk, cannot do anything. Even when you talk, the patient does not mind you. Mention patient's name, nothing. However, when you pinch the patient is able to draw away or move the hand. If you pinch or perform a sternum rub for the patient is able to react to that. Or if you do a trapezius squeeze, patient is able to react to that. Patient is able to react to pain, then you can put down as the pain. So you put the dot as the pain. And if the patient does not respond to voice, as not alert, does not respond to pain at all, that is deeply in deep coma or has been sedated or something like that, that one you put as unresponsive. But then basically, even in the exam, you might not get the chance to even have patients like that because they wouldn't want to make it very difficult for you. They are not trying to fail you. They're not trying to make you fail. They're just trying to assess your knowledge concerning certain things to see that you'd be able to practice in the clinical settings, but they are not there to trap you. However, between the alert and the confusion, there might be a possibility that there may be a patient you may come across that's confused. And so it is very important to know these ones as they are applicable to the exam, in the exams. So what I mean by the confusion part, what I mean is that when your patient is a dementia patient has a history of confusion, whether it is 5 days, whether it is 10 days, whether it is 20 days, and the patient has been assessed before, has been to the hospital before, and it is written within the past medical history as confusion, do not take confusion because it is past. That means that if it has been put down as a past medical history, it means that it has been attended to, that has been tackled, the patient has been reviewed on that, so it is not a new confusion. So if you put that there, you might only be triggering an emergency response for the patient, which is not so. Probably patient is already confused, there's nothing that can be done about it because we have some conditions like Alzheimer's or dementia that can cause patients to be confused over a lifetime, and there is nothing they can do because it's just the brain's work that is happening that way. However, new onset confusion, like for example, in cases like UTI, we can have patients getting confused, or in cases where patients fell and banged the head, a head injury or something, there can be an onset of a new confusion. Like the patient wasn't confused before, all of a sudden patient started getting confused. That is a new onset confusion. So in the question, you may have a write-up saying that patient has been well probably for the past 3 days, like the scenario, maybe why patient came on admission. Patient has been well within the past 3 days, or patient has been well over the week. However, started experiencing confusion in the last 3 days and was brought to the hospital. That is a new onset confusion. Patient has never been confused, but over the past 3 days, patient has been confused, and that is the first time he's been clinically or she's been clinically assessed for that confusion. So that is a new onset confusion. So if the patient came to the hospital based on the confusion, that is new onset, and that is when you are going to take the C instead of, you're going to put the dot at the C instead of the alert. Or let's say if the patient has had confusion, it says that patient has been confused for the past 1 week. So if the write-up is trying to tell you that the confusion is not a past medical history, it is not something that they have been admitted with before, but it is part of the present scenario, the present narrative that they are given. So in the present narrative, if they are saying, however, patient appears confused, or however, patient has been well, or patient came in for this and that, however, patient appears confused, and in the past medical history, there is nothing like dementia, there is nothing there denoting that patient should be confused, that is a new onset confusion because you are the first person, or that is the first time patient is being assessed for the confusion. So it is a new onset confusion. So I don't want us to actually be confused let me borrow the word, not be confused as to where to plot it. So even if your patient has dementia, has a past medical history of confusion, and the patient has been brought on to the hospital, so far as the patient has been brought based on another thing or has the past medical history as confusion, you do not have to take confusion, because it is not a new onset, it's a chronic one. So as the write-up says, he says that for consciousness, score for new onset of confusion, no score if chronic, that it is new that needs to be paid attention to. Okay, so moving from there, we come to the A, which is the temperature. So whatever temperature you get, you put there. As I said, if it enters into the shaded column, you should, or the shaded the colored sections, you should write down the value to prompt whoever it is that this is the value and the reason why the patient is scoring this, or this, for this particular dot in this colored section, this is the value, so that when next the person checks and it's gone up within the same section, the person will know whether it remained the same and it's not anything to escalate, or it's actually is still going up and needs to be paid attention to. So after you've done everything, you now summarize your score. So you check for the respiration, where you put the dot, what the score is against. So the score has been written on the right side. Just map it against there and use the news key to know which one. So you map it against there and you know what it is. So the shaded gray portion within the white background is a 0. The yellow is a 1. The amber is a 2. And red is a 3. Now we know we've got 2 3s. Sometimes you've got 2 3s, 1 up, 1 down, or you've got 2 2s, 1 up, 1 down. It still shows that patient is deteriorating. The only difference is that it's either patient's value is going so high that it is not acceptable, or is going so low that it is not acceptable. Just like how we have a hypothermic patient, which is an emergency, or a hyperthermic patient, it's an emergency, or we have patients that have bradycardia or tachycardia, or we've got patient that's got a bradypnea or a tachypnea, or we've got patient that's got hypotension or hypertension. So it's not only focusing on patient deteriorating. When a patient is deteriorating, it could either be patient is deteriorating into the lower portions, the hypos, or patient is actually deteriorating going above like the hypers. So that's why we've got 3 on the lower side. We've got the figures on the lower side and we've got the same on the upper side. So you can score regardless, wherever the patient is going to. If it's an emergency or deterioration, you'll be able to know. So you look at it, and then when you score, so the respiration, wherever you score, you put it down, you put it in your head, and then you add it. So you continue adding them till you get a final score. And then there is a part that says a news total. So you write the total score there, and the total score might be a 1, a 2, a 3, or anything you get. And then you can look at the escalation frequency to know what you're supposed to do. So per that, I've uploaded something up there that we can all check. So it says that clinical response to news 2 trigger thresholds, and we've got the news 2 score, frequency of monitoring, and clinical response. So if you've got a score of 0, that means that you have to check the patient minimum of 12 hours. So it's a score of 0, you can check the patient every 12 hours. That's the minimum, because there is nothing to be cautious of, or there is nothing to be scared about. However, if it is a 0, as I said, and maybe one of the parameters is at the border and is almost getting into the colored section, per your clinical judgment, you can tell that assessor normally a new score of 0 is supposed to have a minimum of 12 hourly check. However, my patient maybe respiration is 20 and is almost getting into, or it's likely to decrease or increase. So I'll just come back in the next 6 hours to check to see. You can come back in 6 hours. So it's not cut on codes that it should go according to what it is. So this news monitoring is there. However, so if you look at what it says, that the response for first or new trigger with elevated news should not replace clinical judgment in a deterioration patient. if the patient is deemed to be unwell without a raised news, then escalate accordingly, like cold, clammy, reduced urine output. So what it says is that if your patient is actually deteriorating, do not use your clinical judgment. Follow the news score. However, if your patient is not deteriorating, but you've seen a little bit of signs and you want to be cautious, you can use your clinical judgment. So maybe for a score of 0, instead of minimum of 12 hourly, you can come back in 6 hours, just because you think that the respiration was at the border and could either go up or go down. So I'll come back again to come and check. And or if the patient is actually unwell, like the patient is deemed unwell. So for example, my patient has a pain and the pain score is 7/10, or my patient hasn't passed urine in the last 4 hours, or my patient has passed concentrated urine, my patient looks cold, sweaty. All these are not captured on the news 2 chart. That's why when we did the A to E, there are other factors that we considered. So if your patient, whatever the patient is going through, it is not actually captured there, lest I forget, sorry. So with the disability, the part that says P for pain, please do not replace it with the pain you got for your patient. So if you're checking your patient and your patient says I'm in pain, please do not score it on the news score. That pain there is not for your patient having pain or your patient scoring for pain or anything. It is for an unconscious patient. It is for a patient that is semi-conscious or unconscious, that who responds only to pain. Like when you pinch, as I said, or you do a sternum rub, or you do a trapezius squeeze, and the patient reacts to that only. That is when you put the pain. However, if your patient, when you're doing your assessment, says I'm in pain, do not put that there, because that is not the reason why it is there. This is just for level of consciousness and level of responsiveness, and not for any other pain or not for any other voice. Or the V, you do not say that your patient actually spoke to you, so that means patient is verbal and can voice out, so that is a V. No, it means your patient is unconscious and can only respond to voice. When you talk, patient makes signs or something like that, like acts to the sounds or something, but cannot physically open the eye or cannot do anything, and semi-conscious. So please, let's note that. So if your patient is unwell, so patient has a pain and a pain score of 7/10, patient says 7/10, it's high, or patient says I'm in pain, it's unbearable, patient has not passed urine, patient is hyperglycemic. While you are doing your A2E assessment, there is something you noticed about the patient that is not on the news chart. Per our clinical judgment, we know that if the patient is in pain or something, it is something that we need to attend to. So even though your news score is a 0 and you have to come back to come and check every 12 hourly, you have to voice it out to the assessor. The assessor, my news score is a 0 and I need to check every 12 hourly. However, my patient has complained of pain and the pain score is 7/10. So I will come back in an hour to reassess my patient for pain. So you're coming back not to do the news chart, you're not coming back to do the A2E assessment, but you're coming back to reassess the patient's pain. So if the patient looks cold and clammy, or the patient hasn't passed urine, say, so I'll come back in maybe 2 hours to come and check if the patient, to assess the patient's urine output. So you're not coming purposely for the news. So that hourly, the frequency of monitoring that you told the patient, the assessor, that is 12 hours, is only for the news chart. But any other parameters or any other things or symptoms the patient may have exhibited that is not on the news chart, that is of concern, per your clinical judgment, you tell the assessor, my patient scored this, and it's not a cause for alarm, so I'll come back in 12 hours. However, per clinical judgment, patient has this symptom or that symptom, and so I'd like to come back in 30 minutes. I'd like to come back in an hour time to come and reassess that particular one. That's what it means. Failure to mention it that way means that you're actually not being considerate as a nurse, and you're not being professional, and you're not putting patients' symptoms in mind. So you will end up having you might end up getting marked down, because they would say, okay, so patient said this and it didn't show anything. So moving on, we have a total of 1 to 4. So when it's the clinical response for a news score of 0 is continue routine news monitoring. Now for total of 1 to 4, it says minimum of 4 to 6 hourly. Now you inform registered nurse who must assess the patient within an hour. So that is only for if it is a clinical support worker or health assistant or nurse associate that did that, that is when you prompt the registered nurse, so the registered nurse can go back to go and check within an hour to make their own decision. But if you're a registered nurse and you get a news of 1 to 4, it says decide whether there is an increased frequency of monitoring or escalation of patients is required. So that is up to you. If from a news of 1 to 4 you think that is due. So for example, with the SpO2, if the patient is on oxygen, that's a score of 2. Patient being on oxygen might not be an alarm. It's just probably patient is on oxygen to help boost the saturation, and with the oxygen, patient saturation has actually gone up to 96, and there is no cause of alarm. There is no need for escalation. So there are certain things. So 1 to 4, you assess to know, does this patient actually need escalation? So patient is on oxygen, what am I escalating for? What am I telling the doctor? So if patient is on oxygen, what is the doctor coming to do for the patient? Already an intervention has been put in place and the patient's SpO2 is actually up to the normal, but except that the patient is on oxygen, that is not anything to worry about, except the oxygen demand has to increase. Even though the patient is on oxygen, patient is still not making it up to that, I'll say, okay, I'll escalate. But if that, because it's a score of 2, doesn't necessarily mean that you have to escalate. So that's why that's one says that you decide whether you need to escalate or the frequency of monitoring. So it's up to you between 4 to 6 hourly. Now, if you have a 3 in a single parameter, minimum is 1 hourly. So the registered nurse has to inform medical team caring for the patient, who will review and decide whether escalation of care is necessary. Now you consider sepsis. So sepsis is like an infection, generalized infection. So consider sepsis and complete sepsis bundle on EPR if appropriate. Now, if a 3 in a single parameter means that one of the physiological components is scoring a 3. So all the other ones may be scoring a 0, but only respiration is scoring a 3. It is emergent, it is urgent, it is an emergency because it is scoring a 3. Now, each component depicts or shows something. So they stand alone, but they stand together at the same time. So if you have a patient scoring for all of them, it shows that the patient is actually deteriorating generally. But if you have a patient scoring a high in respiration, it means that patient might be having respiratory distress. If you have a patient scoring high on SpO2, it means that the patient is having breathing difficulty. Patients high on blood pressure scoring a 3, hypotensive or hypertensive pulse, it means that patient is actually maybe going into a shock or compensating for something, or patient is in pain, anxious. So each parameter stands alone, however together they also mean something. That is why even if one of them actually scores a 3, it is known as an emergency, because it will be actually denoting or depicting that a particular system, either the circulatory or respiratory or whatever system, is actually deteriorating or something is wrong. Then we go to a total of 5 or more. It means urgent response threshold, and that one is a minimum of 1 hour. So the clinical response is there, what you have to do. And a total of 7 or more, it's quite an emergency. You have to continuously monitor vital signs, maybe every 15 minutes, every 30 minutes, and then escalate whilst you can. So the escalation starts from a news of 1 to a news of 7 and above, but the 1 to 4 depends on your clinical judgment, seeing if the patient needs the escalation. However, a 3 in a single parameter should be something. So if you get a news of 4 and one of them is scoring a 3, just one of the parameters is denoting something, so you need to be cautious about it. So this is about the news too. So when you are in the exam hall, whilst you're doing your A2E assessment, you can actually ask the patients, in order not to forget, can you please give me a moment to document? Is it that you're documenting on the sheets that they've given to you, I'll put it there, or you're documenting straight on the news so you don't end up wasting time? So quickly, you just write the name, everything, then you document, come back, remember to sanitize your hand, continue with what you're doing. If you get another value, you just go quickly and then you document so that your time does not go. Or some people prefer to write everything on the sheet, and then when they are done with their A to E, at a point in it, they just sanitize their hand and take their time to plot everything, but as fast as you can, because you've got just 20 minutes to do the A to E and plot on the news, and then tell the assessor what you got as well. So after you've plotted and got everything, you have to tell the assessor, so on my news, I got a news score of this. because of that and that and that. So if any of them scored, I got a new score of 3 because my patient blood pressure is this, or my patient pulse is that, or my patient is this. However, I am not really concerned because patient says it's the normal, or however, I am concerned, and so I'm going to be monitoring every this or that, and I'm going to escalate to the medical team as well. And then you turn to the patient and tell the patient, so after checking everything, this is your new score that shows that either this or that parameter was like this and that, and so because of that, I'm going to tell the doctors, and they are going to come back to review you. I'll come back again to assess you, and then you know that you are done with that. And then you say, okay, thank you, do you want me to make you comfortable? Are you comfortable? Is there anything you need? I'm going to put my equipment back, and I'm going to document. So this is the call bell, please press on it if you need any nurse. And then you take your equipment back and say, I'll make sure that it is clean for the nurse to use, and then I would document and I'll perform a full hand wash and dab and assessor. I am done. So that is for news 2. So I'm going to do a few plotting so that we can see, and then I'll put the PDF in the comment section so you can click on it if possible. I think I'm going to put the PDF in the comment section. You can click on it and then try your hands on some. I'm going to put some of the figures there, parameters there, a scenario so that you can plot, and then we can see. Then again, I still have my WhatsApp link in the comment section or in the description. If you're interested in a one-on-one class, we currently have one-on-one classes ongoing and it's going superb. So if you're interested in having a one-on-one class, you can take the WhatsApp link, put it in the WhatsApp part. I don't know if the link is clickable, but if it's not clickable, kindly copy it and paste it in WhatsApp, and it will bring you into my general group, and then you can have your inquiries or anything you want to do. If you want to have a one-on-one where I could be performing assessments and other mock trials with you and further explanation, because I can't give everything here, and then we'll go from there. But in the meantime, I hope you understand this, and if you have any question, please drop it in the comment section and I'm going to answer for you. Like, share, subscribe, and follow for more. Thank you. Bye.